And one thing I would say, you can hear me, right? Amy, you can
Yes,
hear me?
we can hear you great.
One thing I would say is because we are going to be trying to be interactive, Marianne and I both are not super interested in talking at you for this talk, is just to start thinking right now about, for you and your role, what are some of the barriers or issues that you've encountered at your hospital, at your site specifically, and then along those same lines, start thinking of what are some of the barriers that you've overcome, and what was the strategy that you took to overcome that you might be interested in sharing, because we will be asking for participation soon. And those are kind of the thematic things. So what are some of the barriers that you are facing or were facing? And then if you have any good solution stories, be thinking of those too.
Perfect. Thank you so much, Alicia. And it looks like we've got quite a good group here today. So once again, my name is Amy Lundstone. I'm a registered nurse and project manager with the California Bridge Program. Thank you for joining us today for a conversation series where we will be hearing from Dr. Alicia Kurtz and Marianne Cox, a substance use navigator, and they will be sharing, we don't have an opioid problem, how to address barriers in achieving buy-in at your site. So thank you again all for being here. And once again, we are being recorded. And Marianne, Alicia, take it away.
All right. So I'll go ahead and introduce the two of us, and then Marianne's going to get us started. But basically, I'm Alicia Kurtz. I'm an emergency medicine doctor in Sacramento, and I'm one of the regional directors for California Bridge. And when Marianne and I originally planned this, it was supposed to be in person at the April training, which we're all still sad didn't get to happen. But it was in direct response to some feedback we've been getting from a lot of sites that, surprisingly, even after almost a year of a lot of our sites doing this great work and seeing patients and connecting them to care, we were still having difficulty at a lot of our sites and other non-bridge sites convincing the regular rank and file doctors and nurses, as well as the administration in some cases, that this is actually a priority. And when you're looking at it next to sepsis and COVID-19 and all these other competing interests, that we were having a lot of our sons and our clinical champions coming and saying, nobody thinks this is a problem here. They're saying, oh, opioids are big in San Francisco, but they're not a problem in LA. We only have meth. Or they're not a problem in Bakersfield. They're not a problem in San Diego. This isn't the East Coast. Opioids aren't our thing. That, or separately, they would say, this is not one of our priorities. And so our thought was that we would like to talk through Marianne's experience as an example of what hitting those barriers is like. We'd love to have a conversation with you about some of the barriers you're facing, and then have a solutions-driven conversation about what you can do with some tangible takeaways to help start to shift that culture and that viewpoint at your site. So with that said, Marianne, why don't you take it away?
Good morning, everyone. I'm Marianne Cox Gould, and I'm a substance use navigator at Howard Hospital in Willits. And Willits is a really rural community in Mendocino County. The hospital is a very small acute hospital. We're just a 25-bed hospital. And the community of Willits is really tight-knit. Most of the nurses and staff at the hospital, with the exception of the physicians, have grown up in the area. So everyone knows each other. In preparing for this presentation, I was reflecting back on the last year, and I thought, my goodness, we got so much done this year. But I had no idea that I would be saying that a year later. So I'll just paint the picture for you. I had my interview for the son position, and it was actually abuse counselor position. And lo and behold, once I had the interview, it was explained to me that it was going to be a totally different role than a substance abuse counselor role. The following week, I went to one of the first, I think it was the second training for sons in Sacramento. And I met the Bridge team, and there were all kinds of acronyms that I didn't know anything about. I didn't know about medication-assisted treatment. I didn't know about the Bridge program. So I jumped in with enthusiasm and came back to my site on that Friday and was ready to get started. So my expectations were that, one, everyone would know about the program. Two, everyone would be on board for the program and excited to treat with medication-assisted treatment. Three, I assumed that I would have somewhere to sit, to work, to do my job. And the other piece of this story, which we laugh about now, is that my physician champion, who had written for our bridge grant, was actually gone for the first 8 weeks starting my role. So I showed up, I had nowhere to work. People didn't know about the grant, they didn't know about the program, and they were not necessarily on board. So the reality was that I actually didn't have anywhere to sit. I remember looking for a spot to put my purse. I sat in our computer lounge for the first 6 months of my role as a substance use navigator. There were a lot of there was a lot of resistance from the ED nursing staff, and just the physicians seemed too busy to consider working with the substance use navigator. And I wasn't getting referrals. So I felt really deflated in the first couple of months of working as a son. So we want to open it up to talk about the experiences, to hear from other sons with barriers that you may have faced. Was it similar to mine? And just give us an opportunity to have a conversation about this struggle.
We want to see you, so I turned it back to gallery view. So yeah, anybody on the call, what are some of the initial barriers? Like Marianne noted, she didn't have a place to sit. Her physician champion was literally physically not even present. What are some of the things that you expected compared to the realities that you faced, or what were some of the barriers that maybe you're still facing at your site? Do it, Lynette. I can see you thinking about it. Do it. You have to unmute yourself. Don't forget. And at the very bottom of your screen, if you hover. Yeah, perfect.
Thank you very much. I am not a son. However, I was on a webinar yesterday with Bridge, and I have been hired under the NTP REACH grant. And your story, Marianne, was extremely like mine. I was my first day was March 30th, so we were all already in shelter in place. Nobody at the clinic other than the director knew what my job was. When I was hired, I didn't even know I was being hired under a grant, or what the grant was, or that I actually already had an end date to my employment. And I'm not truly able to interact one-on-one with people I've never even met before. So had I been out and doing this job previous to the shelter in place, I may have had some rapport already built, but I'm trying to now build rapport with phone calls and emails, and I'm really interested in what the sons who are already out there, who are you talking to when you're at the hospital? Where did you start with getting even any rapport started within the ED? Was it, the charge nurse? Was it the medical social workers? I just was hoping this call might give me an opportunity of knowing maybe who I can get in contact with. I've put a great packet together that has information about Matt, has information about all of our sites for MAT treatment outside outpatient NTP. and also a very easy to use referral fact sheet so that the sons or whomever's in the EDs can just fill out our fact sheet, send it in, and we can get started. But right now, my barriers are our intake. Yesterday in the call, we were talking about a low barrier outpatient treatment program, and our intakes take like 2 to 3 hours. They expect the patient to be there. So I'm just here to learn, and thank you for listening to me. And any feedback you can give me would be helpful.
We are absolutely going to go over the details of all the things that you just asked.
Thank you.
In the chat, we have Rebecca Bartley, Alexis Bucio, and Sophia Laguna and Cynthia Garcia all said that they had an experience very much like Marianne's. I think it's a good example of how a lot of you felt. And how shocked were you, right? Like $100 and something thousand grant, you would think people knew you were coming.
Right.
How did they not know you were going to show up, right?
And my grant was 6 months into a 12-month grant when I was hired.
Yeah. And then we also have Tina Allen saying she also works in a rural area and experienced a lot like Marianne. So it sounds like Marianne, you did a good job of universally describing what people have been experiencing. And so we just wanted to review, like, this is a list of what we thought some of the common barriers were. So nobody mentioned this, Marianne did, but it's not our problem. We had a lot of people saying, we don't have an opioid problem here. We have a meth problem, or we have an alcohol problem. We don't have an opioid problem. That's very rare. There's a lot of stigma. I don't know how many of you heard this, but this like, oh, we don't want to do a lot of work in drug addiction, that space, because then we're going to end up getting more addicts, and we don't want to attract addicts to our hospital. It's not what we want. If you're on the call and you just joined, if you could make sure you mute yourself. We're getting a little bit of background noise. There's also this idea of competing priorities, right? Sorry, we are really busy focusing on sepsis. We're really busy focusing on our front-end redevelopment, or our COVID-19, or our patient satisfaction. That it's too much work, that the providers don't want to spend the time getting an X waiver. That's a big ask, that they're not interested. There's also this idea that's like lack of education and misunderstanding of what we're even doing. For example, people saying, well, isn't this just the new methadone? Aren't you just replacing, one drug or one addiction with another? So with that said, before we go on to our own list of solutions, for all those of you who mentioned that you had a similar experience, what are some of the things that you did to address any of these? Any good ideas, any success moves that you had that you'd be willing to share? I already gave a spoiler that Marianne and I have a list, so we're going to wait for yours first.
Hey everyone, it's
Yeah.
Jeffrey Davidovitz. I'm the substance use navigator at Marin Health. I definitely had a lot of stigma, especially from some of the nurses. When we first started out, it was a lot of like, aren't we just going to become a clinic, and like all these people are going to show up now because of this? And one of the biggest things I did was first find a couple of the nurses who could be allies that were like pretty on board, and right away we're like, oh, this is so cool that we're doing this. This is awesome. And then when you had somebody come in and you started like Suboxone or MAT for them, and you can like see that tangible difference within an hour, maybe go and find some of those nurses that might not be as willing to do this and say like, hey, do you remember that person that came in and like how much of a crap show they look like 15 minutes ago and they were all over the place? Like, go and look at them now and look at how much better they're doing. And like seeing that tangible result really changes a lot of people's minds, because they go, oh wow, like they're not screaming at everybody because they're not in withdrawal. They're not being so rude to everybody. They're actually really pleasant, and like they look so much better. And just seeing that change can really kind of flip a switch for people and be like, oh wow, this is actually something very worthwhile.
That's a great point. Find your champions. It doesn't have to be the ones who are assigned to be your champions. Like find your in the trenches cheerleaders and get them to convert their own people. Like you're not going to be the person that makes all the nurses, for example, buy in. But if you can find a few nurses who are on board and you kind of build them as your champions, they're going to do a better job of kind of converting the culture of their peers. That's great advice, Jeff. Others? What about some of these people who mentioned they had experiences a lot like Marianne? So like Rebecca, Alexis, Sophia, Cynthia, any of you have something that you did that you felt like helped you address some of those barriers?
Hello, good morning. This is Cynthia Garcia.
Hey, Cynthia.
Hello. Sorry, I was eating some chips. I targeted my doctors. For one, I am in a rural area where we didn't have any X waivers at all. So I went to the ED doctors. In the beginning, when I first started, I was kind of pushed to, well, you'll be in the ER. No, you'll be under case management. No, you'll be in the ER. No, you'll be in case. They didn't know what to do with me. So I kind of was handed a folder and said, this is what we have. We all don't know what we're supposed to do with it. Here you go. So I pretty much read. For me, I went through the grant. I read it. I read what the Sun was about, what we had to do, what was our responsibilities, and I went from there. So I targeted my MDs in the ER, my PAs. I went to my champions and my champion, Dr. K, and I asked her, is there a way that maybe with maybe some of the grant money we can give the physicians an incentive to go ahead and get an X waiver? Because that was the main thing. If we don't have any physicians on the X waivers, we really couldn't do anything, even if a patient was coming in. So she said yes. We worked out a plan, and then we put it out, and we got the doctors to kind of get in it. There were a lot of relentless, but for the most part, it was they were okay with it. So we did that. I even sometimes, I mean, I kind of maybe went one step ahead, kind of did some under questions for some of the doctors, but just to get what I needed to get. Then I targeted my pharmacy for an in-house pharmacy to make sure that the medication was available. So that's what helped me. And then I did a lot of outreaching because I got my X waivers. There was a lot of stigma in the hospital. I targeted the hospitals. I'm still having a lot of barriers, but for the most part, it works for me. My patients come in, they're very satisfied. They're linked to a friendly mat clinic, and I try to take each of the patient individually with their own issues because everybody's different, and we just try to accommodate with that. So that's what I did. For me personally, it helped me just reading the grant, understanding what my title was, what I needed to do, and target my MDs. So that's what I did.
It sounds like, Cynthia, you did a couple of things, one of which was you became the site expert in the Bridge program. So when nobody else knew who you were or what to do with you or why you were there or what was the thing they applied for, you took it upon yourself to actually read that grant application and to look through all the materials and to become that source of expertise. I think that's brilliant. So a really good piece of advice that if you're not really sure what you're supposed to do, make it up. Learn a lot about the Bridge program, talk to other sons, develop your own, and become an expert in what you're supposed to be doing. That's really great advice. I also liked what you said about finding a doctor or two, kind of similar to what Jeff said about like find the nurses who are on board to help convert your other nurses. Same goes for the doc. Get a few of them who are going to get X-waivered and show a success story, and then have them kind of help you convince their colleagues at it. And then I think that third thing that you said about do the outreach, like people think you don't have the problem, put the name out there, get it out in your community that you're doing this at your hospital, and the people will come, right? You have enough successes and people's friends will have heard about it and the volume will build, which is good. Alexis wrote that she's still experiencing all the stuff that we've been talking about. The epidemic has now only prolonged the connection with ED staff. I find myself constantly trying to keep myself involved in meetings, emails, outreach, MAT, etc. Any advice on how to basically stay connected to everybody on scene would be helpful. And then Sophia says, I started in January, so I'm still learning, but I was able to connect with the social workers, which has been really helpful. Once I told them about the Bridge program, I've been receiving a lot more referrals from the social workers in the ED in the hospital, which is good. So that I know, I don't see my son from my site on the call, but I will tell you that that was one of the things her name's Jill, felt was very successful, was that she connected with the social work teams on the inpatient side and the ED side. And then that way she was able to really get the word out there, because that's who's often being consulted for patients with substance use disorders or who have some of the other, psychosocial issues that are tied in. And so then the social workers ended up being the ones that would call Jill instead of the doctors or the nurses. So that's a very smart way to get the word out there. I know that not everybody on the call is specifically from a Bridge site. And so I just wanted to make sure that we open it up, that if there's anybody who's not, especially not a Bridge funded site, are there any things that you wanted to bring up, barriers that you want to make sure we talk about in the setting of like not having grant funding to go along with this? Anybody?
Hi, my name's Jaya Garcia.
Hi, Jaya.
Hi. So I work at the Sacramento Native American Health Center as a MAT navigator. I was too a new MAT navigator for the Native Health Center. I'm also White Mountain Apache, and I work with Native American patients. It was during the COVID-19 that I was hired, so I've been trying to adapt and making calls over the phone, outreach with UC Davis, researching online, taking a lot of notes, making sure I'm tracking patients correctly. I came from a methadone clinic, so I have the, it's a higher risk environment. So when I came here, it was a little lower risk, which was good, but I'm still implementing my high risk patients with the patients that I have here. So it's going really good. It's not smooth, and it's a new program. So I have to stay in communication with staff here and make sure that I inform the doctors and staff that are aware of MAT patients and MAT patient care, and how to communicate with MAT patients and what's the necessary documentation. It's been a smooth but ongoing implementation of a lot of documentation. For me, that's really important. And I'm very excited. It's going good. And hopefully in the future, if anyone can contact me in the future for Native American patients, they can refer them to the Native American Health Center downtown. We're also, we'll be opening up a new center in South Sacramento. So we'll have 2 Native American centers here in Sacramento, and just know that we're here. It works. You guys are help. You're like my number one website to go to. You have so much information on there. I love it.
Good. I'm glad to hear that. And I'm seeing other people commenting in here too, also working on basically, like Tina says, making my face present to the medical staff, like somehow connecting with social workers or whoever, so people know you and they think of you. I won't put people on the spot who I know have an answer to this, but anybody want to offer up any of their strategies for how did you get the word out there, whether it was emails or going to certain meetings, or what are some of the things, specific targets that you picked to get people to know who you were? How did you do that? Other than just walking around every day and saying, hi, I'm so-and-so. What did you do? Any targeted ideas or strategies people use?
Hi, this is Cynthia again. I did my outreach where I actually did face-to-face. I did a lot of conferences. I went to a lot of different clinics. I targeted a lot of clinics that had patients that were polysubstance, and they had no MAT clinics. And then I worked with the natives. I reached out to the natives. I joined their conferences. So And then the big one that really helped me was the big one that we had in Long Beach last year. So put a lot of my business cards out there, a lot of my flyers. I handed them to people that wasn't even a part of any MAP program, but they knew somebody or knew how to get a hold of somebody. So I went with even with the insurance, the big insurance that we have down here, down south with the IEHP. I mean, so Rebecca, Wendy, and I kind of like joined together and just kind of spread and helped one another. So I was just I'm not sure the speaker before me, if she needed any advice or any help with her natives. I have a lot of great connections with that too. So.
That's awesome. So Jaya and Cynthia, you ladies need to connect after. We're having some other great ideas in the comments. Camilla says, our team actually distributed holiday cards and candy to the nurses stations last December. Brilliant. Really smart, right? Having it like in a way that everyone's going to come and get your cookie or your candy, whatever, but it's from this specific team and kind of highlighting what you do. That's very smart. And going to the nurses stations is a great strategy. Tina Allen also says she physically presented to the ED nurses about who she is, what she is. She has one scheduled to do the doctors and with the local clinic. So Cynthia mentioned this also. That's a really smart idea. Reach out to the director or the coordinator of the clinics and say, hey, is there a meeting? Do you guys have a staff meeting ever that I can get in front of and I can join? The other thing I'll throw out there that's kind of what they're saying here too is like nurses often have a shift change huddle, or they'll call it stand up or something like that, making yourself available to go both on the inpatient and the ER side to the huddles and stand ups and saying, hi, like I'm so-and-so, I'm the son, this is what I do. That's a really great strategy as well. Awesome, these are great. So on that note, we wanted to just cover some of our thoughts about some of the solutions that you could take home, and then we'd love to continue talking about other solutions that any of you have employed at your sites that have been effective. So the first one, and this I think it's so clear how important this is because it's been mentioned. I mean, Jeff mentioned it, Cynthia mentioned it, multiple of you in the comments mentioned it. Building rapport with providers, nurses, and don't forget your pharmacists. Whether that is you scheduling time to do formal education for them, again, reaching out and asking when people's staff meetings are is a really good idea. Almost everyone has a staff meeting, at least at some point, quarterly, monthly, something that you can go be a face, and then spending time to find out what their needs are. What are their questions, addressing those questions. I know multiple sites, one of my sites that I work with at Reading, they actually put together a contest where they had gift cards it was like the first 20 nurses who identified a patient in opioid withdrawal. You didn't have to do anything except for be the one who identified it and called the substance use navigator. And they had these gift cards they handed out, which was a really fun activity. So you can make it fun just to build awareness, because it sounds like all of you were experiencing the same thing where half of your hospitals didn't even know you were going to be there. So building awareness of the program. Practical solution number 2 is making sure that you recruit the right person to speak for you when you need to. Cynthia gave this good example that we needed more doctors X-waivered, so I went to my physician champion and I said, you're the doctor, you need to get your doctors X-waivered, right? You, depending on what your role is, making sure you're going to the right resource. And if you want your inpatient pharmacy team to get on board, it might be easier if one of your ED pharmacists who's very familiar with the program goes with you to help present that information and answer questions. Just because, or like Jeff was mentioning, he had some nurses who were really on board. Then you want those ones to help talk to the other nurses. And part of that is just because they speak the same language. So if you're a substance use navigator, you'll know that having a conversation with another substance use navigator is easy because you speak the same language, you have the same perspective and experience. In some ways, you understand each other. And that's true of doctors and nurses and pharmacists and hospital administrators. And so it often helps to just make sure you're targeting any education you're doing. You should, if you're the substance use navigator, you should go. I think your face should be all over that hospital, but making sure you're bringing a buddy with you who's going to be the right person to help you speak that language and answer the questions that are going to come up with the group that you're presenting to. The third thing, if you're at a site where they believe we don't have an opioid problem, which to me is one of the truly biggest barriers, that people think this is not a priority. We hear that a lot at our site. Then take some time to work with your clinician champion or your nurses to teach the team that you are working with the right questions to ask. So saying, do you use drugs? Do you use heroin or fentanyl? Yeah, maybe sometimes people are going to say yes, but you're going to miss a huge percentage of patients that would really benefit from our services and our help. And so teaching them things like, sometimes if we suddenly stop taking certain pain medicines, we can have the symptoms like you're feeling. Do you normally take, Norco or Oxy or Percocet by any chance? Which is a really different way to phrase things than, do you use heroin? Are you addicted to opiates, right? Same thing with, do you normally take any pain medications at home? That's it. And then yes or no. When was the last time you had them? And maybe it was 48 hours ago, and now they're here with a flu-like illness that's actually opioid withdrawal. So again, educating our staff on how to ask questions in a way that's approachable without stigma, and that gets past the one everybody asks, which is, do you smoke, drink, or do any drugs? Are you sure? Okay, next question. That's not enough. So we need to do a good job educating our team. The next thing is combat ignorance with data. So if there's anything that we can tell you about people who work in healthcare, science and data should at least rule the day. And so if somebody's telling you we don't have an opioid problem, these next two slides are for you. Feel free to take a picture of your screen. That's what these are here for. This is a map, a heat map of opioid use issues in the country, clearly showing that California specifically has an opioid use problem, that we as a state are one of the hotbeds. This is not an East Coast problem. It's an everybody problem, but look at us. We score higher than most places on the East Coast. So I feel like I often hear people saying like, oh no, this is a New York problem. It's an East Coast problem. No, it's a California problem, or it's a Seattle problem. Look at Washington. They have less opioid use disorder than we do in California. So this is a good slide that you can keep a photo of on your phone. And anybody who wants to tell you that, you can go, actually, here's a really good map kind of showing you that this is a problem for us in our state. This is a map of the state of California showing the actual number of opioid-related deaths by county, as well as overdoses or drug poisonings by county specifically related to opioids. So you can also take a photo of this. It's not super helpful if you're in one of the counties where it's not affected, but I will tell you the vast majority of our bridge program sites are in the sites where we are seeing this, where we're in more of like the red areas. So are these slides provided at the end? Yes, of course, we're going to show them later. Don't you worry. But these are for you to kind of take a quick picture of, put on your phone, bust out that data when somebody tells you it's not our problem. Yes, it is. And here's the data to prove it, which just means we're missing it if you don't think that it is. Next solution. This was mentioned in a couple of different ways, but I want to say it explicitly. Learn the hospital and physically, feet on the ground, go meet everyone. And in this era of COVID, use video chat to your advantage. So start with the people that you know. Go to your emergency department champion, for example, your clinician champion. And if you are not personally familiar already with the medical director of the ER, so the doctor who is the boss of the other doctors in the ER, ask to be introduced to that person and make sure that you've been given some face time in front of all the ER providers. Same thing with the person who is usually called the emergency department nursing director, and or they'll have a nursing educator for the ER. Those are some two key players. That's kind of going to help you get to your nursing and emergency department clinician staff. You want face time with those directors and ideally with those groups, even if it's a pre-recorded video that you ask to email out. Is it an online training that you help develop and ask them to assign? Is it going to the nursing stand-ups, the huddle to say hello? Is it going to the provider meeting, whether it's via video conference or in person? Then from there, you can ask those leaders to help connect you to the inpatient leaders. So the nursing director, for example, in the ER is going to be familiar with who the nursing director is for the OB unit and who the nursing director is for the medical surgical unit. And so maybe you then, once you've gotten to know your ED nurse director, you say, hey, I would love it if you could connect me to the nurse leaders on the inpatient side so that I can chat with them about spreading the news. Do the same thing with your social workers and your case managers. Start with your ED group, and then once you've built that relationship, ask for them to introduce you to the inpatient side. And then walk the floors of the hospital. Go to the nurses' stations. I love the Christmas card candy idea. You know, do something, hand out your cards, walk around, get to know people. Learning about hospital and who the key players are can be really challenging. So don't be afraid to ask a lot of questions about how the hospital works. It's not an intuitive process at all. But getting to know each of those units and using who you know to introduce you to the next person so you can go to that next group of learners, it's going to be really important to you. And I'm going to hand this one over to Marianne as our last final solid piece of advice here.
So we love to talk about this idea of the Sun Navigator as being a superhero. And often we are asked or expected, or part of our role is to be able to respond to many different things at the same time. And especially responding to crisis. So what I found was that what I was really able to bring into my role was to be my best self, to be authentic, and to draw upon the strengths that I have with my personality and in the other areas in my life that have been challenging. And so for me, I am outgoing. I really enjoy people. I like to ask questions. I like to smile. But this is just part of my personality. And so we really wanted to invite everyone to kind of think about this as your personal toolbox that you bring in with you every day when you walk into your site, and or if you're working remotely, that you start your day really trusting and knowing that you have this unique toolbox that makes you the best Sun for your site. And so to make a list for yourself of your strengths that allow you to do this work. And just remembering that you're working with patients who are often in crisis or they're struggling. You're working with nurses. You're asked to present to doctors. You are, interacting on many different levels. You're expected to do outreach and education. And so to really remember that when it gets hard, to draw on those parts of your personality that allow for you to do this work. And you don't have to be extroverted. You don't have to have the strengths that I have, but to remember what yours are.
Right. And so the idea being use each other as a resource to find out how other people did things, but don't beat yourself up if you don't look just like Marianne as a Sun, or if you don't look just like this person as a Sun. Let yourself bring what it is that you do the best. So if you're a great educator, put yourself in front of these groups and teach them. If you're not, maybe you're better at putting together PowerPoint slides and resources, but then handing it to somebody else who's a little more extroverted than you and getting that person to give the lecture. Great. So don't feel like you have to do things that are outside of your strengths, and don't be afraid to lean on other people to fill in the gaps and to let yourself be the Sun that you are for your site, which is awesome. And so speaking of which, we'd love to kind of we're still going to have a conversation a little bit more, but we wanted to wrap up a little bit. So Marianne talked about what it was like when she first started. Literally didn't even have a chair to sit in. And clearly now we've made some progress. So Marianne, why don't you talk about that a little bit?
Sure, I'd love to. Thank you. And I have really found that I've had to become very humble and often scoot my ego out of the way in this role. And that is one of my best strengths in this past year, because there are many, many times that I felt discouraged, that I felt frustrated, that I felt confused with resistance and barriers. So we are 1 year and 3 months in starting the Bridge program at my site. And, I would say that we have a robust inpatient MAP program. I am busier than I can even respond to on the inpatient side. I have learned almost all of the nurses' names and have a pretty close relationship with most of the hospitalists. I am now getting referrals in the emergency department. I don't sit in the emergency department, but I have carved out a little office space for myself in our Bridge clinic, which happens to be on site at the hospital campus. And that works for me because I'm able to, my daily rhythm is I go to all of the huddles and I check in with both the hospitalist and the ED physician. And then I walk through the ED several times a day just to check in and remind staff that I'm there. We went from having 6 waivered providers to having 18. So that feels like a really incredible strength to have. And at this point, it seems like this is part of our routine practice of care, is to treat people with medication. And I think one of the biggest strengths that I really have received from my support through the Bridge program is, and a lot of that came from, you know, practicing harm reduction and being positive and compassionate and supportive of these patients, but also seeing the people who were creating barriers for me in the same light, so that I would not confront them with my own resistance and resentment. And I was persistent, but I had gentle persistence. So I was smiling, I always said yes, and I was grateful. And I made sure to ask them what they needed from me and from the hospital to support them to do the work. So we are definitely in the flow, and I could really use a second son because I'm too busy.
Marianne, you actually brought up a really interesting point that I'd love to ask the group about that we did not address specifically in our solutions list, but this idea of stigma that you mentioned, where like there, you know, you continued to be a smiling, yes saying face until other people got on board. I know without, like, if you could show me your hands, you would, but that every one of you has encountered stigma at your site. I'm confident of that. And I'm curious, does anybody have any good advice? I have mine, but I'll save it. Anybody have any good advice for the group, like ways that you have addressed stigma, whether it's among providers who don't want to get an X waiver because they're like, these are addicts, they chose this, I don't care, I have better things to do, whether it's nurses who are not very polite maybe to this population, whether it's, you know, I don't know. But what are some experiences you've had and strategies you've taken? Rosemary, I want you to unmute yourself and talk about what you just wrote, because I think you're actually really good at this. Rosemary Gomez, do it. Are you there still, Rosemary? I saw your comment. I know you're here. If you're on the phone, you push *6 and it will unmute you.
Rosemary, you should be unmuted. Give it a shot.
She sometimes has tech issues. She's one of my sons. Okay, I can speak a little bit. Rosemary, if you can talk, I would love to have you do this. But Rosemary wrote "Kill 'em with kindness." She is a great example of this, and kind of like what Marianne was saying. Rosemary is just always smiles, always positive, always like a fierce advocate for each of her patients. And I think it's interesting watching how at her site, specifically at San Joaquin, as people get to know her and respect her just as an individual and like a coworker, and they watch how respectfully she treats everyone, it really does rub off. The way she treats people does rub off. So I think that idea of living the example is one very effective tool, and honestly probably a mandatory part of making any kind of changes. You have to be the change. Rosemary's blushing. You're so sweet. Okay. Anybody else? Other thoughts besides kind of being the change?
I have one actually. This is Felix from Queen Valley Hospital. I'm actually in a weird transition right now because I originally worked at St. Vincent Medical Center for the son there. And then the hospital got bankrupt. And then so now we're on transition to like a different site. So I'm a very
Wow.
weird transition right now. But weird thing is I'm still following up with some of the patients, older ones. But I would say like one of the things that what I did when I was in St. Vincent was that there's definitely a lot of stigma. It's in downtown LA, and you know you have tons of patients coming in. The red phone is raining. Always, you know, no, I can, no, I can, no, I can, and then it's always, you know, it's like you can see them, they're sweating, they come in, they're sweating, and then pretty much the people is always like, oh, they're coming again. Like all the nurses are always like, oh yeah, here they are. You know, there's a lot of stigma from the nurses, definitely. It was definitely one of the huge challenging when I was on the road, on the spot, because they were like, oh yeah, you're the expert, just hop on in. Thank goodness there are a few of them that they have actually some experience with opioid patients in the past, like they worked at like a methadone clinic, things like that. So I just cling on to those one or two like nurses all the time. Like I'll be like, oh, you have those patients, let me know. Like I always told them. And then they slowly kind of spread the word. So I agree with the Jeff when he said like, oh yeah, link with your nurses, like that definitely helped. Definitely a lot of stigma. And what I did was that I definitely remember that that two nurses. One of them was George. Okay, I don't think I should say his name, but but George, basically the nurse. He was dealing with one patient, and then he came to me, and he didn't know what my role is. I think he was a travel nurse, so he came in and then he told me, he was like, dude, like this patient bed 1, blah 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 blah, like look at him all sweating and he deserve it, blah blah blah. And I was like, internally I was very frustrated. I was like, no, you should, yes, he struggled with this, but he's a person, you know, if you're in his shoe, this will happen to you, exact same thing, you know. But I didn't say it in front of him, but I told him like, oh, you know, I'm actually a substance use navigator here, and my role is this, blah 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 blah. Do you want me to handle the patient? I can get him off your hands. And when you say that, like he loved it, because he was like, oh yeah, get out of my hands, you know, let's work for me. So after dealing with the patient, linking him with him, and following up the patient when after his discharge, right? And the other couple of days, I know that he went to a MAT clinic. He went to BART for his Suboxone there. And so I when the next time I saw George, I told him, I was like, hey, remember that patient, bed 1? He was like, oh yeah, that guy, blah, blah, blah. I was like, oh yeah, hey, you know what? Like literally, he actually decided to go in the clinic and he wanted to change. And, you know, I lied about it, but I told him like, oh yeah, he was appreciative of you, you know, what you did there. And then, yeah, that changed his mind a little bit actually. And then later on, there was another patient and he linked it to me. He was like, oh yeah, we have this patient on methadone. I don't know if you're interested with him or not, but you know, if you want to, you can talk to him. I think that made him humble him a little bit, I guess, but it also humbled me to not bring up my wrath on him, you know. I was like telling myself like, okay, you know, this, not everyone's into this, not everyone wants to, you know, help this endangered population. So yeah, I definitely learned a lot from that. Literally what Rosemary, kind of killed him with kindness. Like you have a lot of wrath and you really fight for your patients, but not everyone's on board, not everyone knows what you do. But the main point is that you kindly tell them and kindly guide them to know what the program is and know how we can help them better. I think that really can transform the whole environment and the vibe there, one by one nurse by one nurse. And it's funny because at the end, I have pretty much, at first I cling on to that 2 nurse that was in the methadone clinic and they had those experience. But later on, we have at least, I would count like, I would say like 10 to 12 nurses that I know that they always call me and they always tell me like, hey, dude, they just grab me by the hand, but like, dude, bed 2 needs you. Like, come on, let's go. And then like, hey, bed 3 needs you now. Let's go. And so, yeah, like one by one, kill them with kindness really is true. Thank you, Rosemary.
I think that, Felix, what you just said about the one person at a time with intention, the way that you, for example, came back to a person who is not a believer and you said, hey, do you remember that patient you took care of? I want to update you about how they're doing. And by the way, they really appreciated you helping them link to care. They really appreciated you being a part. That, I think, don't underestimate the power of that. And so take, you know, if you've got your nasty anti-drug addict sort of staff members, if they do have a case that you're involved in, I think that's a great advice that Felix just gave, that come back, follow up. When you follow up with that patient a week later, go find that nurse, go find that doctor and say, hey, remember Mr. Smith that you started on Bupe last week? I just talked to him. Oh my gosh, he's doing so great. Like, he's never felt this good. He's actually applying for a job. Like, he moved back into whatever. You know, give those positive successes. The other thing I will say, you know, Felix, you said that you didn't say this out loud, but something that I would recommend, I use this phrase a lot. I just say, name the elephant. I say things out loud that most people don't say out loud. And I think that we should all feel empowered to not be afraid to do that. And I'm not saying be a flippant jerk. What I'm saying is, when when someone says, oh, the druggie in bed 8, I will say something like, that's a pretty outdated term. And then just kind of wait for a second and be like, we don't really call people druggies anymore, but are you saying that the guy in bed 8 has a substance use disorder? And then I just kind of move forward. And if you're just like, the complacency is part of the problem. So you don't have to make people feel bad. You don't have to be rude. And when I've had people argue with me, for those of you, I know there are a lot of you out there who have some personal tie to substance use, whether it was you yourself or someone that you love or that you care about. I'm very open about this story. But my little brother actually just died last month from a fentanyl overdose after a long struggle with opioid use disorder. And so I tell people, when I hear them being like rude, I will turn and I will just very calmly say, you know, my brother uses heroin. And I'll just kind of wait for a second. And now, like last week, I actually said, you know, my brother recently died of a fentanyl overdose. And I just kind of shrug and I'm like, these aren't bad people. Like, you know, there's really good evidence-based treatment. Like, we probably should just be nice to them. And so if you have, not everybody has that, but if you have something and you're willing to be upfront about it, again, not in a rude way, but in a very like matter of fact, point blank, it really does humanize it for people. I actually still sometimes randomly get texts from people I used to work with who will say, you know, I saw a patient with opioid use disorder today and I was totally thinking about your brother. Like, this person was driving me crazy and I was able to be more patient because I was remembering you telling me about your brother. That kind of stuff sticks with people. So, and I think it's tied a lot to you, sort of what Jack was saying in the beginning, like put the time in to get to know everybody. And then that way the things that you say, they mean something. They carry weight when you say, my cousin did this, my mom did this, my brother did this, I used to have whatever. And I'm not saying you have to do that, but if you're comfortable doing it, those kinds of honest, pointed, non-attacking, just factual-based one-liners can be really powerful and can stick with people. It might not change how they feel about drug addiction in their hearts, but it might change the way that they treat people, and that's you know, a huge part of the battle. A couple of other comments in the line. So Tina Allen says, I stay patient. I trust in the process that in time they will see the benefit in the some position. I think that's what everyone's kind of saying too. Believing in the good in people and leading by example, treating people who use in a kind manner will eventually become contagious, right? So you show that it looks so much nicer to be nice and people will learn that. Or like Felix says, I'll take that patient off your hands. I'll show you it's actually easy for me because I'm just nice to them and I enjoy it. And that becomes a thing other people think, wow, that is a lot less painful than how I usually treat people. Camilla says, I keep a lot of internal stats regarding outcomes and I submit the data to my managers when we submit our site data, and then they share the outcomes at their hospital. Yes, we mentioned this as one of our ideas, right? Use data. Always, like, it's such a great idea to use data or examples. People love examples. So if you're, say, a substance use navigator, a physician champion, don't be afraid. Every few months, the clinician champion at my site, every 3 or so months, will put up de-identified 2 success stories of people that we've treated with Bupe and how they're doing now. That can be really powerful, just reminding us that maybe not everybody does really well, but this is the difference that we're making. Great job. We have about 3 minutes left. Is there anybody else who has something that they wanted to share?
Hey, this is Rebecca from Apple Valley. I just wanted to say thank you. And I think that the patients, you know, just treating our providers and our nurses with the same patients that we treat our patients with, our participants with, is a really great strategy, because they don't teach what we're doing in medical school or nursing school. And so this is new to them, and new can be scary. And so when I first started, I just really dove into our algorithms, the Bupe algorithms, and got to know them like the back of my hand, and was very hands-on, you know, with the providers, like walking them through it, literally, like helping them gain the confidence, and just kind of like showing them like the harm reduction ethics behind it. And yeah, I had a lot of like disbelievers at first, and I had to like use that personal story, like you said, you know. I had a physician and a PA talking about a patient, and like literally I just talked to them about it. They turn around to themselves and start saying, oh, this person will never change. You know, this person doesn't want to change. And I just like quietly, just like you said, one liner, like, people can change, and I'm living proof of that. And they just shut up. And that
Yep.
PA, like now one of my like biggest supporters, he like loves the Bridge program. He took it upon himself to do webinars and like teach himself about harm reduction and safer use strategies. And he loves helping this patient population now, because, you know, it's just like showing someone that it's a human thing, you know.
Yep.
It's not a cultural stigma that we have to like stay entrenched in, because it is cultural. I even tell participants all the time, like, don't like inner stigmatize yourself. Don't bring that upon yourself, because it's a cultural thing. It's fictional. It's not real.
Yeah. And interestingly, we have a side note. I run a podcast. It's called Real Talk. And we're doing a series with the Bridge program, actually, that we're so excited. I'm sure you'll hear about that when we're done with it. But one of the stories that we're going to share talks about this, how actually a lot of the stigma against drug use comes from the medical community. It doesn't come from regular people. Like movies and stuff glorify drug use, right? Like most of the negative stuff is honestly bred into our medical field. So you taking the beat to say, pause, this is not a thing that we have to act this way about is really powerful. So with that, I would just like to say thank you, all of you, for your participation. It's so much more fun to have you talk with us and share your ideas. We will have the slides available to all of you, like they mentioned in the comments. We'll help make them available to all of you. And then Marianne and I are both, you know, happy to take questions. Our emails are on the slides that will get sent out too. So feel free to reach out to either of us if you need anything, or use your Slack channel if you're in the Bridge program Slack. So thank you all for your time. We really appreciate it.
Thank you so much for all of you being here. And a big thanks to Alicia and Marianne. You guys did a wonderful job. We really appreciate all of your knowledge and contributions to this really important topic. And like Alicia said, we'll be sending out the slide deck and some follow-up information. I did put a link in the chat box about a Get Waivered event that's happening on May 20th. This is a free virtual event for NPs and PAs and doctors. There's about 300 seats left, and it's an opportunity for them to complete their X-Waiver training from the comfort and safety of their own home. So we'll send that link as well. Thank you all for being here. Hope you have a great rest of your day. Stay well, stay healthy. Bye-bye.
Bye. Take care, everybody.